So now I would like to introduce to you all Dr. Jane Brock.
Well, thank you. That was very comprehensive. I didn't realize we had submitted that in my introductory comments, but it is true. We are increasingly thinking of the problem of hospital readmissions and of healthcare utilization in general as being something that requires a social movement for solutions. So we've really pretty fully embraced that at the QIO and yeah, trained ourselves in community organizing. It's fascinating. I think I'm going to talk about that part more tomorrow, what we've learned about that and how we're trying to apply that. Today I'm going to talk about just sort of a kind of a general overview of what it takes to implement care transitions interventions. But, you know, first, who here is from a hospital or hospital system? Okay, and nursing home or long-term care facility? Okay, rehab hospitals? Anybody here? Hospice? Home health? Okay, very good. Physician offices? Okay, great. Area agencies on aging or other community service providers? Okay, very good. And are there physicians in the room? Okay, nurses? Okay, good. Social workers? No, social workers? Oh, how are you guys going to do this? Okay, anybody else I've missed? Somebody here? Community organizers? Pharmacists. Oh, pharmacists, of course. All right, very good. Okay, so just to kind of give background, this really has been an evolving scenario, and the reason I want to include that information is because it is still evolving. You know, I would say the majority of what we need to know has yet to be written and discovered. So that's a huge focus of our work right now with the QIOs is we have, I think there's 260 some communities now officially recruited and working with QIOs. To convene sort of community-based infrastructure through which readmissions can become less necessary. Anyway, we need to, there's still no roadmap. I got to tell you, there's no roadmap. So what happened in QIO talk, we have scopes of work and they're each 3 years. So we've just started the 10th scope of work. But so in the 8th scope of work, which has been roughly 6 years ago, Colorado just happened to get funded for these 2 little pilot projects on literally the same day. So we were running them concurrently. And one was to see if we could orchestrate providers who depended on each other a lot. So, you know, a group of providers that shared hundreds of patients a year, to see if we could make their processes more efficient to literally loosen up some FTEs to supply Eric Coleman's coaching model. So you know all that rework around transfer of care, we actually followed hospital discharge planners because we were going to map their processes. And I mean, holy cow. They were walking around with a phone on each hip, you know, like the Wild West, and they could be on one phone when the other phone rang and that bed fell through, you know, stuff like that. So after 11 days of following hospital discharge planners, we started calling the process "It Depends" because we couldn't find we couldn't flow that job at all. So we went to having folks from other settings follow hospital discharge planners just so that they could see what the chaos is like. Since we had a hard time actually describing the job. And boy, that was a really informative, that was a tiny part of the project. And I have to say, everybody who observed hospital discharge planners said something along the lines of, "I love my job." But anyway, we had a lot of insight through that. Well, so we had these folks, we had 3 communities trying to simplify that system so that they could supply coaches to you know, at-risk discharged folks. At the same time, we were running a 4-state pilot where we were trying to recruit hospitals to intentionally target some elements of what was considered to be non-beneficial utilization. And those 4 states were New Jersey, New Mexico, Colorado, and California. So it was interesting. On both coasts, hospitals chose to work on appropriate use of ICU services. So, you know, reducing their rate of admitting sort of pre-terminal patients to the ICU. And in the middle, the hospitals were far more interested in working on issues related to transitional care and reducing readmissions. So as those 2 projects were going on together, we finally just morphed and we got permission from CMS to put the resources of the Transitions of Care pilot into the communities that wanted to reduce their readmissions, such that we convened community coalitions to deliver coaching services to reduce readmissions, and that was the portion of these 2 pilots that was outstandingly successful. I mean, it just worked. So that became the 9th scope of work pilot, in which we tried to replicate that in 14 communities, and that worked also. And so now we're into 260 communities, trying to really spread this as a standard way of doing business. So the premise is actually quite easy, and in some ways it doesn't even have that much to do with readmissions specifically, but it's more. I think we need to get to the place where we think, who lives here, what do they need, and what's my role in that? And so it's okay for everybody to decide what their role is in a vacuum, but it just goes a lot better if you work with everybody else who also has a role, and just intentionally structure roles, responsibilities, and therefore infrastructure planning and care planning for a population that lives here that we all serve together. So anyway, that's the evolution of all these thoughts. Now the 14, a lot of what I'm going to talk about is what we learned from these 14 communities. As you can see, the West was unfortunately underrepresented, but we have lots of communities in the West now to learn. A part of understanding who lives here and what do they need means you kind of got to live there. So we're very interested in this concept of local context, because I think maybe 50% is an evidence-based intervention and 50% is the local context in which you're trying to implement that, and nobody else can really tell you that, which is the reason you've got to get down to effective community-based coalition management. So I feel like I have to put in this disclaimer. I know I and many others tend to use transitional care and reducing readmissions as if they were the same thing. They are not actually the same thing. There are many things that that improve the care transitions experience that do not give you immediate reduction in hospital readmissions. However, since the focus, I think, for hospitals especially is to reduce their readmissions and prove that they're reducing their readmissions, I'm going to talk mostly about the readmissions reducing aspects of transitional care improvement. We've confused them a lot because we know that gaps in transitional care do obviously increase risk of readmission. And when we talk about evidence-based models, the evidence has always been grounded in whether or not the model reduced readmissions. So in a way, the readmission rate is sort of a proxy measure for the quality of care transitions, but I just want to point out they are not exactly the same thing. So out of all 6 years of working with a number of communities and hospitals and coalitions, here's what we call our driver diagram. Now I got to tell you, there's no data behind this other than we just have never seen a community yet in which it didn't come down to these 3 things. So if you look at why are people readmitted, at the provider-patient interface, and this is without assigning blame, people finish with an acute care intervention unable to manage condition worsening. There's a lot of reasons for that, but just over and over. They go home, they're educated, they have the brochure, they have everybody's phone number, but they don't manage condition worsening. Secondly, if you review medical records when people come back to the hospital, and I'm sure all the hospitals here know this, you would not say most of them are taking guideline-driven medication regimens. And there's a lot of reasons for that as well. But anyway, over and over again, we just see that this sort of ideal medication management is missing. And thirdly, this very fact they choose to return to an emergency room. So in terms of, being in boxes as opposed to thinking out of the box, so this whole returning to the emergency room, I used to think about this kind of like, do I really have to prove that night is darker than day? Like everybody knows that. And one time I made this comment, they all go back to an emergency room, so of course they're admitted. And there was a guy in the audience who was from England with the National Health Service, and he asked the question, why is that? That was the first time it occurred to me that is actually a reasonable question. It's very directly related to the same thing all this readmissions activity is related to, and that is the perception of other options. And that's where it comes down to community-based focus. Either your ED docs do have other options or they don't. And if they have to think about it more than about 5 or 6 seconds, that's not another option. They're in a hurry. Anyway, there's a lot of great work to be done, and I would say we've barely scratched the surface on this particular element, how a hospital could disconnect darkening the door of an emergency room from being readmitted. All right, so if we know this, and we do know this, and this is not new news, we've known this for a long time, you have to ask why again. All right, so why do we have these 3 things? If we've known about it for a long time, why is it not fixed yet? And that really is because I call it unreliable system support, but actually we have no system to support, really. And so every time in all the communities I've worked in, it really came down to these 3 things. If you ask why do we have this patient-provider problem? It's because really we don't have, it's rare, it's becoming less rare, where we have unaffiliated, unrelated providers having sat down and done what in any other industry would be called supply chain management. You know, intentional, mutually interdependent process that is measured, hopefully 100% of the time, so that they can hold each other accountable. You know, Toyota doesn't just shrug if, like, all the screws to put on the hubcaps don't arrive on time. I mean, you know, they do something about it because they measure it continuously. So, you know, anybody who manages a complex system usually spends a lot of time both developing the process and measuring the process. And, you know, we've just never really done that before. Secondly, I'm not going to talk too much about unreliable clinical information transfer. I assume everybody here lives with that problem every day. And then thirdly is this idea of patient activation. So, you know, we've given a lot of lip service to, and I don't mean that in a sort of a like careless disregard way, but we talk a lot about patient self-management, but there's actually a lot of evidence that just having a contact with an acute care medical provider is very deactivating in and of itself, and it's not anybody's fault. But so the definition of activation is knowledge, skills, and confidence. Okay, so having a terrible new diagnosis that sends you to the hospital, well, that's kind of a confidence destroyer right there. Having managed as best you can some chronic condition that really worries you all the time anyway, and having had to go to the hospital because it got worse, is a very it's difficult to feel confident in that environment. Well, by the time folks are discharged, not only are they sort of at a low point, to say the least, there's a lot of instructions, a lot of activity. They meet hundreds of new people. It is quite difficult to go home, no matter how much information you have, and use that to take action. So, it's just education and activation are very, very different. And so as medical service providers, we need to go out of our way to activate people. It's pretty clear, as opposed to just sort of expecting them to get it. Okay, so we have these system level issues, and we've known these also for a really long time. None of this is new. Not only have we known this for a long time, we have a large number of evidence-based models that pretty much address all or one of these three system level issues, right? How to standardize information transfer, how to standardize process, how to activate patients. All right, so we've known this for a long time. It's the same, at least in 14 out of 14 communities it was. If you guys can think of another one, let me know and I'll add it. So the issue that happens, I think, and in 14 out of 14 communities, the reason this problem wasn't solved is because there was no place to solve it, really. So, there was no standing meeting, not even an annual meeting, in which the purpose was for people across the spectrum to get together and talk about how it's going around here. To what degree we serve the same patients, and how do we know that, and how are we thinking about that, and how would we like to improve. So this is where we really got to. It's community coalition building, and by extension community organizing. All right, so I'm going to go through the top four actual interventions. That there are other evidence-based interventions, and I'm going to show you a table later on in the talk. But all right, so the one that was the most used in the care transitions theme and is the most used in the new demonstration program, which I'm going to call the CCTP. You guys will know what I mean when I say that. But yeah, demonstration project. So is the coaching model. So this is Eric Coleman's model, and it is a coaching model. So I thought I knew what coaching was. I have actually been through the training and even taught parts of it now 7 times. And I would say in retrospect, I didn't really get it until about the 3rd time. So anyway, as caregivers, we think we understand it before we understand it. But the coach really does not give medical care, and it's quite important that the coach not to give medical care. If the coach does something for the patient or gives medical advice, they have become yet another provider. And the problem is there's already a lot of providers and a lot of advice in their heads, in their homes. There's too many people already. What the coach does is goes directly to confidence, self-management confidence, and gives people a framework for how they might start to get their arms around this. It starts by having patients set goals for their life, their wellness, and then identify potential barriers toward that wellness that might be anchored in their medical treatment needs, and to help speculate and take action on ways they might address those barriers. The coach has exactly 5 contacts with the patient. They introduce themselves in the hospital. They do a single home visit, and that visit is around medication discrepancy notation. So We talk a lot about medication reconciliation, and now I think it's probably inexcusable that we as providers can't reconcile the beginning of our appointment with the patients to the end of our appointment with the patients. That's really important. But when they get home with a perfectly reconciled medication list, they've got, I don't know how many other lists, depends on how many specialists they have, and a house full of medication. So when you suggest to somebody they should reconcile that, reconciliation implies that you have a gold standard list, that you know which one it is, and you're going to match up to it. So that's a concept that's really not relevant for people when they get home. So what the coach does is teaches people to sort of tabulate what their concerns are with a plan for who they're going to call to solve them. This drug looks exactly like the one my cardiologist told me to take or told me not to take or whatever. And what I need to do is call that office and get this question answered. So it's really a medication discrepancy resolution skill. They also use personal health records and encourage people to keep them. Now, the coach does not record anything in the personal health record. This is to be owned completely by the patient. So really coaching to me is the difference between parenting infants, which is caregiving, and parenting teenagers, which better be coaching or you're in trouble. So it's the only evidence-based intervention in which the evidence was based on 30-day readmissions, randomized controlled trial. And it reduces 30-day readmissions by 30 to 50%. So now the most common issues with this is having caregivers do a combined caregiving coaching role. You will not get these kind of results if you're doing that. So the coach needs to be a coach, hands-off, and the caregiver is the hands-on person who helps them take care of things. So I'm happy to answer any number of questions about that. All right. The second model that has randomized controlled trial level evidence, it's just that Dr. Naylor used 90-day readmissions as her measurement endpoint, is the transitional care nursing model. Now, as opposed to coaching, this is a medical care model. This requires a nurse, ideally an advanced practice nurse. This is a nurse that accompanies the patient from the hospital to the home, does home visits, accompanies them to the first few outpatient office-based visits. They do a lot of sort of coaching of family members. They actually do caregiving, though. They are a nurse that is assigned to people. So for instance, severely demented people who are trying to age in place, this is a much more intensive intervention, but also overall saves money and is evidence-based. The transitional care nurses are usually involved in the lives of these folks for about 4 months, and they do transition themselves to sort of adequate, the services are set up for folks to be cared for at home with this model. Okay, Interact, are people familiar here with Interact? Okay, so Interact is quite a comprehensive toolkit that is designed to help skilled nursing facilities / long-term care work productively with hospitals to reduce their rate of acute care transfers. So not every acute care transfer is a readmission, but every readmission is an acute care transfer pretty much. And so this is a really wonderful toolkit. Now the evidence is not there yet for 30-day readmissions only because they have not measured and published that. But there's a number of really great tools there. One of my favorites is, it's called a tool, but when you think about it, this could happen with a conversation as well, is where nursing homes systematically submit to hospital emergency rooms their capabilities. There are some nursing homes that can insert feeding tubes and whatnot. There are some that have x-ray capability. There are some that do not, many that do not. So sometimes nursing homes are transferring patients to the emergency room for an x-ray, but as said before, they are admitted because they're really sick, that communication wasn't clear. Let's face it, emergency room doctors are a little bit impatient and may not have a totally positive view of nursing home capabilities. So one of the most powerful tools in this is just getting hospitals to understand the capabilities of the nursing homes that are within the geography where they might send patients to them occasionally. All right, and then there's a group of protocols that I have lumped together as hospital discharge standardization protocols. Now, these are completely within the walls of the hospital. The two most common, certainly Project Red has gotten a lot of attention, and Project Boost is more of a structured way to have hospital discharge planners and hospitalists become quality improvement leaders. It's actually very good. I want to point out that, so Boost has not published yet, but RED, I hear this miscited all the time. RED by itself does not have statistically significant evidence of reducing hospital readmissions. It did reduce them. It did not meet statistical significance. They used a combined endpoint of either ED visit or readmission. So had the N been larger and they had more time and all that, one assumes that it would have reached statistical significance. But, in a way, this kind of confirms what we think, which is, maybe, if I had to just guess, and this is a complete guess, maybe 40% of the hospital readmission problem is controllable by the hospital, by things they can do within their walls. And the rest is really up to the receiver capability. You either have a place where people can stay, or you have a place where they're constantly at risk of coming back to the hospital. So that's true for community settings, that's true for institutional settings. It really is completely within the interest of the hospital to make themselves part of coalition work for this reason. Okay, so in reality, as the 14 communities were rolling out all these interventions and trying to reduce readmissions, we had to target, we had to target a population of people, and that population was defined by zip code of residence. It was our very first ever foray into population management. So our population was defined by a line on a map. If you live here, you're in my population, and I'm trying to reduce readmissions on your behalf. So that meant that if somebody in my community in Denver, was discharged from the hospital and went on vacation to Florida and was admitted to the hospital, that went onto our statistics. So it was really for this population, how are you going to reduce the readmission rate? So a number of providers, of course, paired up and worked together in groups, and there were many interventions going on. But in reality, most adapted the interventions, adapted the models or the components of models, and in general, that is to be encouraged. I'll say a little more about this later. If you are adapting them based on what you know about your own local community. Now, it is not okay to go online and see how Cincinnati adapts their model and think, oh yeah, we'll do that adaptation too, unless you're sure that everything that is relevant about your community is exactly the same as the community whose model you are adapting. Anyway, most people did put these together, and as they rolled out, they sort of adapted and combined interventions. And in every case, they tended to take a dual track approach. One is activating patients, and one is, getting your infrastructure together. So I think of it as, if we need people to cross from one place to another, they need skills to do that. On the other hand, we shouldn't have to require the skill level of a tightrope walker. We also could build a bridge that would be a little easier to navigate. All right. So the first thing, the most important thing we learned is that patient activation trumps all. So this is, I took this from Gary Larson's What the Dog Hears. You really cannot tell how activated a patient is from talking to them in a typical clinical encounter. People are socialized to say, oh yeah, no, that's really, no, I got it. They also can tell that you're trying really hard. And so when they ask, do you have any questions? They're, oh, no, I don't have any questions. Half the time, the question, do you have any questions, is actually an ineffective way to elicit feedback. My husband, who is not a medical service provider, always tells this story. So as a young, perfectly intact person, he found this instruction very confusing. Here's your antibiotic. Take it 3 times a day with food. Do you have any questions? No. Do I look stupid? Take it with food. Got it. Go to the pharmacy. They go through the whole thing again, right? Any questions? And they have all those little international symbols on it. And then you get to the office and you realize, oh, it's time to take my medication. And then he said, so, okay, all right, if I had a pizza for breakfast and it's now 11 o'clock, is that food? Or I'm really hungry. I think I'm going to eat like the whole pizza because I'm really hungry right now, and then I'll take my med. Or maybe I'm not hungry now. It's like half a piece of pizza. Is that food? And so in the end, if you were to take this to a ridiculous extreme, his real question is, if I don't get this food thing right, does that mean the drug won't work, like it has something to do with absorption, or am I just risking, indigestion? Because the one, I'm happy to accept whatever. I'll live and learn, and I'll do something different with food. If it's not even being effective, then I really do need to have the answer to that question right now. So when you ask people, do you have questions, and they're not facing the decision in the moment, they don't have the questions that they're going to have. So just to make it clear, This is not a criticism of current hospital discharge practices, nor of teaching practices, nor of availability of educational information. You cannot expect people to phrase the questions they don't have yet in a way that you can effectively answer them. That's why it really takes home coaching follow-up. You can coach people to think about asking important questions in the hospital if you had a lot of time. But I think that still wouldn't work. People don't get it until they're there and they realize, oh, yeah, I didn't think it would be this way, and I actually do have this question. All right. So we talk about patient activation all the time. I just have to point this out because the chronic care model was kind of like, it was the Bible 10 years ago for quality improvement, right? And it wasn't until I got all involved in coaching that I realized, maybe you guys have noticed this the whole time, all right, we're busy trying to be prepared and proactive practice teams so that we can have productive interactions with informed and activated patients like they're just out there. Like when we find them, we're going to have productive interactions. So, we're really not going to find them unless we sort of get into the business of creating them. So as chaotic as information transfer is between providers, and I put this in because, primary care is a game of tag in which you can be it without ever being tagged. It happens all the time. Well, we discharged them and told them to call their primary care doc. The doc has no idea. They were even in the hospital. So in the best systems, we know that hospitalists will directly tag a primary care doc about 20% of the time. So that's pretty terrible. On the other hand, the person who's it 24 hours a day, 7 days a week, looks like that lady. And, that lady might actually even be a caregiver for someone else. So, twice a day, that lady makes a decision. Am I going to ingest that medication or not? So really, if we don't get to her level of self-management capability, really, we're never gonna win this game. So in addition to coaching, in terms of patient activation, I just want to make you aware of two other things. So this is really the best one because it's free. CMS convened an impressive panel of experts to develop this CMS Discharge Checklist, and it is a checklist to patients and families. It is not another checklist for providers. The second greatest thing about this is that it's designed to be used in any setting. So this could be a community-based intervention in and of itself. And the third greatest thing about this is it has CMS's logo on it. So it doesn't have to go through your forms committee. It can be directly from CMS to your insureds. Your legal department doesn't, at least in the 14 communities, people were like, oh, you could even say that you don't like it, but CMS, thinks you should have this. There has not been data collected on it. I actually think this would be a fantastic data collection tool as well. I know the discharge planners and the care transitions team who used this found it to be a really interesting and useful tool for them to use. They really didn't know what people didn't know at the time of discharge and often didn't have the time to find out. But it can kind of help guide a discharge conversation in a way that helps you. Okay, and the last activation thing is the patient activation measure. And I'm not going to go into a lot of detail, but just to let you know, there is an actual measure of activation that does not depend on hospital discharge. So the PAM it's unfortunately proprietary, although it's quite inexpensive. It is a 13-item survey that basically stratifies patients into 4 buckets based on their level of agreement with what I do is important for my health outcome. So there are people who don't think that what they do has a role. And I got to tell you, as a physician, those people scare me to death. Oh, I just do whatever you tell me to, doc. I'm like, ugh, oh my gosh, this is trouble. And then the highest activated level folks say, I know what to do, and I'm confident that I can do it, and I can maintain those behaviors even in times of stress. So for everybody who ate more than they wanted to at the last holiday, you are not at the highest level of activation. So I think that's probably all of us. Anyway, patients who are at activation level 4 are the ones that providers often find really irritating. They're the ones that won't go away, that just keep asking. They'll look it all up on the internet and they'll say, no, that's actually not the best drug for my lupus. What do you think about this one? But actually we should be encouraging that. Those folks do well when they get their questions answered. We used the PAM in Colorado to help us target our coaching program, and it was extraordinarily helpful. So when we started without the PAM, just doing a straight Coleman model, and our coaches felt like, we all felt like, our patients, Colorado's great. Everybody's about a 3. They're really sharp. They really know what they're doing. These folks they're just delightful. But when we actually measured them with the PAM, it showed that when we were starting our coaching intervention that most of them were 1s and 2s. So from here. And then we used the PAM to evaluate sort of the impact of the coaching program, whether or not it was actually activating people. And so after they completed the coaching intervention, then the majority were 3s and 4s. So the PAM is actually a very, very helpful tool. Okay, so the first thing we learned is that patient activation is really the trump card. Secondly, last phase of life perspective is important. So this is from The Onion. The world mortality rate is just not going down at all. So seriously, I work with Medicare, and Medicare insures people from 65 until death, right? So whether or not you think that people are about to die isn't really the question. We've been asking the wrong question for a long time. What we have is an accumulation of chronic disease. So chronic actually means incurable, right? If you have heart failure, there's no cure. If you have diabetes, that's not curable. So this is from Joanne Lynn's work, and she always says, well, okay, we can't tell people that they're going to die or this is fatal or, those are too strong of messages. But so she says, we should just say, you have a combination of chronic challenges that are likely to be present at your death. In a way, that is the best way to say it, So really, why would we pretend like this isn't going to be there, and we can sort of, probably sort of predict in a general way how it's going to go, but we're not having those conversations. So I just want to point out, this is also Joanne's work because I found this to be very helpful in my thinking. She says there's basically 3 ways people in the U.S. die. They die of single progressive terminal disease, cancer, some neurologic problems, used to be HIV, and I think people don't die from that anymore, but anyway, single progressive terminal disease. And it was a huge breakthrough in the 70s. I actually remembered this when Elizabeth Kubler-Ross's book was published. And so finally, as a culture, we started talking about death and dying. But she was really talking about predictable death and how you could embrace it and that kind of thing. Well, so if you were just to plot function by time with 100% being, hopefully how most of us are here, and 0 being death. If you look at single progressive disease, we actually have a great deal of data that shows that you can kind of predict when people are starting to go down. And so do people know? Oh, it's on there. Oh, it's on my slides. So I'm going to ask this question. Anyway, it's predictably about a 4 to 6 month thing. And, it's led to innumerable TV shows. How long do I have, Doc? That kind of thing. It's about 4 to 6 months, and that is the hospice benefit. That's why it was said at that. However, that's only about 25% of the deaths in the U.S. right now. Another 25 to 30% are really what you would call multiple organ failure. And this is your readmission population, right? So what happens is, and it seems dramatic, but if you don't step back, you don't see the pattern. So, somebody gets, a cold, right? This is a cold in somebody with heart failure, renal failure, osteoporosis, depression, diabetes, and COPD, which is quite a common combination. And so we buff them up, right? We put them in the hospital, we buff them up, and they're like back to normal. They go back and they do all their normal stuff. And then, a few months later, it happens again, and we get them back to normal. And it isn't until you step back that you realize, well, this isn't really, they weren't maybe quite normal, but whatever, they went back, they're playing bridge, going to church, whatever. Do you know how long this on average period is? When you're sure they're going to die to when they die with this kind of patients. So in the support trial, it was 14 hours, which is why these folks did not get hospice. They did not have a DNR sign. People just weren't sure. And so it's not until you step back and say, you know what, actually we sort of could have predicted that something like this would happen, sooner or later. So this is really the population that is the readmission population. And so we call this problem heart failure. But you all know it's not really just heart failure, right? It's this combination of multi-organ failure. The last one is dementia frailty. That's becoming an increasing proportion of deaths, and I'm not going to talk about that too much, although if your readmission problem is emanating from this, then you need to call up your long-term care facilities and start working on Interact. Okay, so local adaptation is inevitable. I kind of said that before, but it really is a chicken and egg problem. It's your local context that has probably caused your readmission problem to begin with, if you have a readmission problem. I mean, so readmissions are a direct function of local context. So not adding local context into how you want to approach it is just a mistake. Okay, the fourth thing we learn is to ask your community to help. I'm going to go over this. I have a session tomorrow on community building, so I'm not going to talk about this too much here. And the last thing is measures. I just feel obligated to tell, especially hospital folks, about measuring readmissions. This is our actual data, which I had to take all the numbers off because it's pending publication. But so in the care transitions theme, we started out, like many other initiatives now funded by CMS, with what I call the proportionate readmission measure. And the measure is something like number of readmissions in the numerator and number of discharges in the denominator. And the reason for that is because, as of the present time, we only create measures for the purpose of holding providers accountable, right? So we have to attribute it to a provider. So it's number of discharges, number of readmissions over number of discharges. So this was the interim point of our project. It's right here. So this was not good news. So using that measure, we had failed dramatically. But when we added up the actual number of readmissions among the 14 communities, they were down by about 11%. And that is because, of course, readmissions are also discharges. So when you go about reducing your readmissions, your denominator also goes down. So it sort of depends on the relationship between the numerator and denominator, whether or not this proportionate readmission measure is going down. So the solution to that we found, and it was great because we had targeted our communities by zip code of residence, was to look at number of readmissions over the population at risk of admission. And that's the measure you all want to be able to use. So QIOs can help you make that measure for your community. We are making those measures. We can update them quarterly. We're calling them a balancing measure for now. But if you're embarking on one of these initiatives measured by the proportionate readmission measure, you ought to have this as a balancing measure to put somewhere into your results portfolio. Okay, so how to develop a community project to reduce readmissions. I've kind of just to summarize it, to kind of put together the steps. First of all, you need to know who's in your community. The QIO, I believe, has done this for you, has identified a number of communities here in Arkansas. You need to do a root cause analysis to figure out what is driving your readmissions. The drivers and the settings you need to work with will tell you exactly what interventions you might think about, and then you need to form a backbone agency. All right, so this is how I think about it. So this is commonly used as a picture of dysfunction, but actually it's not so dysfunctional, because when you think about it, if you're going to reduce readmissions, so I guess the hospital could go to their boardroom and say, well, we want home health. We think they should do X, Y, or Z. And they could, and that used to be kind of the old style approach to it. But, really, seriously? Maybe you should ask somebody who has a lot of really direct, narrow experience with what home health does and what their constraints are, how they think about quality, how they hold themselves accountable. So you really do need a bunch of super specialists, and I mean sort of situation specialists, not necessarily like cardiologists, but I mean people who actually go into the home and do, provide services to give you their perspectives. You then need a way to connect the people who need to be connected so they can do meaningful and shorter work together. And then you need a way to evaluate overall, is it getting better or isn't it? Are we making progress or not? What are our priorities here? Some way for coalitionness to help understand whether it's working or not. Okay, so who's in my community? This is what the QIO can do for you. This overlaps zip codes, people who live here, with services provided. So you can take a large metro area and kind of carve it up into a more manageable place. So we did ours in Denver, 44 zip codes overlapped with 3 hospitals and, 3 or 4 nursing homes and 5 home health agencies. About 60% of the services delivered to this place. If you get to greater than 50%, that's good. You can say, here's a community where we're going to start. We can use claims data to map relationships that should be there based on numbers of shared patients. So, when you think about it, a transition has 2 sides, a sender and a receiver. And if you map that as this is social network analysis, as if that was a relationship, you can really very quickly see who ought to work with who or where you would get really quick gains. So this is, if you map every single transition in a community, it looks like that, and it's kind of a mess. That's not too useful, in my opinion. If you go down to say, I want to see all the providers who have more than 10, relationships per quarter. You get that, and at the lower right is if you go to more than 30. Anyway, the point is you can test all different cut points, and you can say, oh, now I get it. We got to start with Hospital A and SNF CC. Now, these social network maps are based on the population that lives in the place that the QIO is working in, has defined community. So, for instance, it might seem that Hospital A is larger than Hospital C, and that is not true. I know this community. Actually, Hospital C is quite a bit larger. It may also look like this is a really problematic relationship because a red line means readmissions. It's a two-way relationship. And that is not true. Both of those are exemplary performers. However, Hospital C and SNF CC, Hospital A and SNF CC provide a lot of services to this neighborhood that we're showing on the map. So yes, they also generate the most readmissions. So a social network map cannot be used to evaluate provider performance or to compare provider performance, but it can very quickly show you where you might start your work. Okay, so root cause analysis, I don't know, everybody has data, reviewing medical records. Actually, the very best source of data is patient interviews. And for those of you who are hospitals, keep in mind that your hospitalists are actually paid to interview patients and record their answers. For readmissions, the easiest data source I can think of is having hospitalists ask, why do you think you were readmitted today? Or why do you think you're in the hospital today? And record it in your own words, which is, sort of a sacrosanct, inviolable thing about the chief complaint. The physician's supposed to record it in the patient's own words. All right, so when it comes down to if you think activations are a problem, we really need to get working on that. And by the social network map, we need to do it with, all the physician offices in our community. What inevitably happens is the project within even a single community sorts into pairs, clusters, where hospitals just want to standardize their product for, the way they do things for their main receivers. Certainly the multi-stakeholder coalition has barely been tested. We think that's a really important part. But I just want to point out that, so this is what I think is the most promising way to go, to tell you the truth. So when the care transitions theme first started, there were a couple of communities where we got the feedback from the QIO, oh my gosh, these hospitals will not sign the charter until they know every other hospital will sign it. This sort of intense competitive vibe. I would say the most common situation in which that happens is with regard to home health. And I have to say, when I first heard that, I thought, oh, holy cow, those communities will never get it together. But in the end, these were the really high performers. And when you think about it, it makes sense. So I'm going to use home health again as an example. Sorry, I don't mean to pick on home health. But home health, at least in my experience, has been so competitive that they are detailing the hospital discharge planners all the time. They're sort of amplifying these kind of specialized programs that they're developing. I understand they're marketing their services. But in the end, the hospital discharge planners kind of want to hide from them when they see them. It's just like the drug reps, in a physician office. And they're really actually confused about what home health can and can't do. They can remember best case scenarios with home health and worst case scenarios with home health. So when home health gets themselves together and says, we're going to make a coalition of the 10 home health agencies that serve this community, and we are going to set our own standards. This is what we do as a profession. This is what constitutes best practice. This is what we are going to hold ourselves accountable for, and this is where we need the hospital to integrate into this. Then the hospital can respond to a single thing and idea. They don't have to develop a custom product for everybody they discharge to. So this turned out to be incredibly powerful, and that was a lesson for me. So I would actually encourage you in these community coalitions to start there. So this is just an example. This is a couple of home health agencies who were affiliated, who were just sick and tired of the whole medication reconciliation thing, and they got with the large regional medical center, and they found a champion, a pharmacist champion, and they had a series of meetings. This wasn't any, and they decided who's going to call who and how, who's going to be responsible for what, so they could do pre-admission through post-discharge reconciliation, and they reduced their readmission rate by 5% in like a couple of months. This is my favorite example, and this is from Harlingen, Texas. So Harlingen was the community with the highest readmission rate at the beginning of the project, and the QIO data showed that something like 30% of all their readmissions were coming from long-term care facilities. There was a long-term care facility in Harlingen that had a 40% 30-day readmission rate. So almost half their folks were going back to the hospital, yeah. So what happened is a physician champion emerged who was just outraged. He was a medical director at one of these facilities. And he said, this is insufferable. We have to stop this. And so he recruited, engaged with, cajoled, berated his colleagues into forming this group of medical directors, and they all agreed to hold themselves accountable for seeing patients within 48 hours of arriving at the nursing home. So, the conditions of participation, shockingly, still say 30 days, and that a physician has to see them within 30 days. So they said, obviously, that's ridiculous. It's been ridiculous for a long time. They decided the standard should be 48 hours. They started to do it, and they explained something like 4% of the overall readmission rate in Harlingen went down related to this effort of this lateral coalition. Okay, so drivers plus settings equals interventions. This is a table that is available on our website. Just want to point out, if you know who you need to work with but have no idea what you might want to do in the way of need a tool or a resource or something, they're all out there. You don't have to invent anything. So now, forming a backbone agency, I've already said quite a bit about this. You need a way to overall track community progress, keep people motivated, hold people accountable, help set priorities, agree to a common measurement strategy, that sort of thing. So if you have all of that, and you have even a month or two of data demonstrating that you're reducing readmissions, then you can apply to the CCTP program. So this is a fee-for-service payment to an agency that can deliver transitional care services not otherwise paid for under Medicare, which is most of them, to have that reimbursed on behalf of your community. So the basic idea is there's $500 million that was allocated for this. It is not actually part of the ACA funding. This was funded separately, so even if the ACA gets overturned, this program will survive. About half the money has been allocated, which means half has not. So it's a pretty simple idea. You have hospitals, acute care hospitals, that form a partnership with a community-based organization to deliver services to high-risk beneficiaries at the time of discharge, to keep them at home. This guy's at home. It could be wherever did you send them to keep them there. You have to produce data and have a plan for tracking data, and this can be simple count data. We had 60 readmissions last month, and we only had 45 this month. It does not have to be statistically whatever kind of data. And if you can do that, then the CBO can get paid for those services. It has to be not a provider that bills the Medicare program otherwise. So this is a whole new experiment in actually paying fee-for-service for community-based services in general. It doesn't have to be services that happen in people's homes. It could be some other things. I'm happy to answer questions if you guys have them. So anyway, no matter where you are, if you're just starting to get your community together, the QIO is now funded to help you get your community together, get the interventions, collect the data so that you can apply. If you're well along the way and you have the latest, greatest intervention, you've adapted it for your community, it's demonstrating huge benefits, then you can get support through the CCTP. Both of these were meant to lead people towards ACO and bundled payment structures. I'm not going to talk about those because I'm not an expert. Also, I'm not sure anybody is an expert, really. There's a lot of experiments going on. But anyway, this was supposed to be a way to get paid to help develop ACO-like infrastructure. So this is just a picture of our website where everything I've talked about today is on our website. It is, I'll get you the URL. I thought it was on here, but anyway, it's not very complicated. So this is always my conclusion. I can't say it any better than Jerry Garcia, who said, it's clear that somebody has to do something, and it's incredibly pathetic that it has to be us. But that really is kind of the mantra for community-based action. And when you think about it, who would you like to have do this? I mean, so Baltimore can just regulate the heck out of Medicare and Medicare payments, but really who's going to get it together? I mean, if not us, on behalf of us, it's really never going to work. So that's all I have. I'm happy to take questions.